First of all, thank you for having me speak to you all today. I'm nervous for a couple of reasons. The first being that following that panel is maybe the most challenging thing that I've maybe ever done. And secondly, I'm quite used to talking in forums where it's a lot of kind of politicians and those types of people who frankly don't know a lot about drugs. So I'm now in a room of total experts, so I find that quite intimidating. So I hope you'll keep that in mind as I try and take you through this presentation. So I was asked to give a bit of a global overview of harm reduction. For those of you who aren't familiar with Harm Reduction International, a project that we do every couple of years is we try to look at what's happening around the world in terms of harm reduction and try to map progress or the lack of progress and try and kind of set a baseline for what's going on around the world. And we just released our new report a week ago, so you're very lucky. You're one of the only third audiences, I think, to get this information. But as was mentioned earlier, I'll talk about different interventions and how they may have upscaled or regressed. But at HRI, we see harm reduction really as more than interventions. It's a policy framework for how we should be approaching all drug policy. And that's the way we've always tried to think about harm reduction in those sorts of terms. But having said that, what I will do is just try and give you a snapshot of what's going on around the world. So in terms of the global state of harm reduction, which is the project, this is the 5th report in the series. So we've been collecting the data now for around 10 years. We publish the report every 2 years. We tried to collate independent information. So this is a unique project in that we don't just rely on government data, but we go to civil society groups, drug user activists, anyone working on the ground to try and verify information around what's happening around the world in terms of harm reduction. And as such, it's the only independent source of global harm reduction data. We tried to provide you with a snapshot of harm reduction worldwide. It doesn't cover absolutely everything. It couldn't. It's already 150 pages long if you want to read the whole thing. So we tried to give you as much information as accessibly as possible. It's a completely civil society-led effort. We work with regional harm reduction networks where they exist, regional drug user networks where they exist, and experts. And we try to make it accessible. So not only do we have the report, but if you look online, we have kind of infographics and a map which you can kind of click on, hopefully enabling you to kind of access what you need when you need it. So first of all, I'll talk a little bit about needle and syringe programs. So as you can see, we have this slightly blurry map of the world. And in terms of what's going on for needle and syringe programming globally, for the first time since we've started this report, what is quite a worrying development, I believe, is that since we started publishing in 2008, no new country has implemented a needle and syringe program since the last time we reported. Normally we see a small progress over the couple of years, 1 or 2 countries implementing a pilot, perhaps. But since we reported in 2012, 90 countries worldwide have a needle and syringe program in place, and that remains the case in 2016. As you can see from the map, needle and syringe programming is available in the community, and that's donated by red. Needle and syringe programming is available in the community and in prisons, and that is donated by the black, very small number of countries. And the grey countries are where we either don't have any information or nothing exists. I would also mention that this really doesn't give you an idea of coverage or quality. It's just an indication that something exists. It might just be one project running a pilot. Maybe it's not even up to scale. It very unlikely isn't. Many countries don't have needle and syringe programming up to scale, but it kind of gives you an idea of what's going on. In terms of opioid substitution therapy, the picture is a bit better, I'm happy to say. 80 countries operate opioid substitution therapy. Now, for those of you who are really into our reports and really keen on this, you'll know that the number hasn't changed since we last reported in 2014. But what I would say is since we reported in 2014, OST has been newly implemented in 3 new countries, which is Monaco, Senegal, and Kenya. When we previously reported, OST was available in Bahrain and the UAE. The situation has since then changed, and it's only available for detox purposes, and as such, we don't class that in terms of opioid substitution therapy, which is why the number hasn't changed, but new countries are implementing. And it's also perhaps important to note that some central barriers to implementing these services still exist. OST, for example, remains illegal in Russia and Turkmenistan. And in Malaysia, although OST is available, punitive enforcement means that people who use drugs often refrain from using these services, and this is definitely something that happens around the world. A couple of key issues that we wanted to highlight in terms of the findings this year are harm reduction in prisons. This is an area that is really of major concern for us, and I think for the harm reduction community in general. Harm reduction in prisons lags far, far behind that of what's available in the community. And in fact, as we've been tracking the data over the years, the one area that has in fact regressed, as opposed to gently increasing over time, has been needle and syringe programming in prisons. It hit a kind of high point in 2012 when we reported that 11 countries had at least an NSP in one prison in some way. Now we're reporting that 8 countries have a needle and syringe program in a prison, so several have shut since the time that we last reported. And those 8 countries, if you're interested, are Armenia, Spain, Kyrgyzstan, Moldova, Germany, Switzerland, Luxembourg, and Tajikistan. So an interesting range of countries, for sure, not the UK, but an interesting range of countries. But they all provide NSP in at least one prison. But what I would say that the only country that has anything up to scale is Spain. Everywhere else, it's a pilot, it's in one prison, and it really isn't meeting the need of those who require it. And also since 2014, we're reporting, although it's very difficult to confirm, that Iran closed its needle and syringe program in a prison, signaling the end to such services in prisons in the entire MENA region. More encouragingly, perhaps, we reported a 21% increase in opioid substitution therapy availability in prisons. In the MENA region, OST has been initiated in at least one prison in Lebanon and Morocco, which was a big step forward for that particular region. And despite the increased risk of overdose in the weeks following release from prison, just 6 countries globally currently offer overdose prevention training in the lock zone to some prisoners, and that's the UK, Spain, Norway, Canada, the US, and Estonia. I think given the fact that 1 in 5 prisoners worldwide are held on drug charges, and the current figures that follow it shows that really that provision is increasingly urgent for people that require it. And yes, of course, we advocate for decriminalization of drug use, and of course people should not be in prison for drug-related possession, but we should also recognize that drug use happens in prisons regardless of that, and these services are not just a policy option for states, but they really are a legally binding human rights obligation. And it's been found in some cases that the denial of opioid substitution therapy can even constitute inhumane and degrading treatment in some cases. So really, this isn't just a case of a public health. It is a public health emergency, but it's not an option. It should be something that should be in place in every prison in the world that requires it. Another area that we felt was important to highlight, and I think this is probably not news to anyone in this room, but is the increasing urgency around overdose-related deaths. We've seen huge increases in different countries around the world that are incredibly worrying, and as Kirsten mentioned earlier, entirely preventable deaths. And this is why it is such an urgent situation and one that has been neglected for far, far too long. We reported a 327% increase in drug-related overdose deaths in Canada, 137% increase in the US since 2000, a 64% increase in the UK since 2014. Everyone in this room also knows that's the highest recorded rate of drug-related overdose deaths in this country since we began gathering this information, and a 61% increase in Australia since 2004. And what I would also say is this is only where we have this information. This information is rarely gathered well. So really, I'm looking at 4 countries and I'm telling you it's an emergency situation, but that doesn't mean it's not the case in other countries. I'm sure it is. We just don't always have the right information. So I thought, you probably can't read this, don't worry, just look at the map. What I thought I would also do is just talk a little bit about the situation in Europe, given that we are still, for now, in Europe, and this might be the most kind of relevant information for you in the room. And so, in Europe, I think it's often seen as, and it is, a leader in terms of a regional harm reduction approach. Harm reduction does exist to some extent in most countries in the region, and in most cases it is scaled up to an extent. But since we last reported, in 2014, what I would say is that while needle and syringe programming does exist in every country within Europe, Western Europe as we term it here, provision has declined in several countries, including Austria, Belgium, Finland, Germany, Luxembourg, and Norway. And surprisingly, the largest decrease we reported was in Portugal, often seen as a country that really leads harm reduction in terms of its decriminalisation policies and its related reduction in HIV. But actually, it is kind of predominantly due to austerity and due to being pretty badly hit by the 2009 financial crisis, has seen a reduction in funding for programming and therefore a reduction in some of the service provision. In terms of OST, around half the people who use opioids in the European region do receive OST, but the coverage varies wildly, from very low, for example, in Cyprus, to very high coverage in countries like Portugal. Another area to perhaps touch upon, and we've talked about it a little bit today already, is drug consumption rooms or supervised injection facilities. We all know that Europe is kind of the home for this particular intervention. Most of the drug consumption rooms that are available globally are available here in Europe, with further facilities being established firstly in Switzerland and then in Germany, the Netherlands, Spain, Norway, Luxembourg, Denmark, Greece, and France. Currently, across the European region, we have 87 of the 90 globally drug consumption rooms, running. But unfortunately, the one drug consumption room that did start to operate but then was closed down was that in Greece, and that was in 2014. So we have seen a regression. However, Norway and Luxembourg are preparing to open a second drug consumption room, and we saw France opening drug consumption rooms this year just before this report was published. And we're very excited by the possibilities in Scotland and in Ireland, where really for years we've seen a bit of a stagnation. No new countries were really opening drug consumption rooms. It was very steady in terms of the ones that did have them in operation. And now we're seeing a bit of an increase, which is really heartening for those of us who want to see more and more of those services in place. But so often, as with most of harm reduction, political resistance exists, and it still exists here in Europe. In Bavaria, for example, in Germany, despite the high rates of drug-related deaths, the regional government did not open a drug consumption room despite a lot of pressure to do so. So that was a missed opportunity in our perspective. And really worrying, given the fact the rest of Germany operates most of the drug consumption rooms in Europe. It's a strange dynamic. In terms of other areas of drug-related harm, hepatitis C is the clear area of concern around the world, and this is also the case within Europe. Prevalence rates remain very high amongst people who inject drugs in the region, ranging from 14 to 84% globally, around the region, sorry. So in terms of just sort of moving forward and thinking about other areas that we could perhaps be considering, one of the main barriers to scaling up harm reduction services globally has really been around a lack of investment in the programming. Each year, we spend around $100 billion on law enforcement approaches to drugs. Conversely, we spend around $160 million in harm reduction services in low and middle income countries. So that's about 7% of what we estimate is required to scale up more globally. So when we think about the stagnation of harm reduction services at this point, combined with political resistance, is also this problem of a sustainable funding mechanism. So at HRI, we launched a campaign last year calling for a redirect from punitive law enforcement services programming that we know doesn't work to harm reduction. And what we did was we decided to try and look at what kind of impact a small redirect of that $100 billion might have on the global harm reduction response. So we're asking for a 10% redirection, which would definitely fund HIV and hepatitis C prevention, treatment and care for drug users globally, but would also cover things like naloxone and investment in peer programming as well as networks of people who use drugs. And we worked with some colleagues at the Burnett Institute in Australia to do some modelling to say, okay, if we just had a small shift in funding, what impact might that have in terms of HIV prevention, for example? And we worked with them because we're not mathematicians ourselves, and these are the results. So just a small shift in the current funding for punitive responses to drugs of 2.5% would see a 65% drop in HIV-related deaths amongst people who inject drugs and a 78% drop in new HIV infections. And as you can see, we are seeing a decline. Overall, that's the line on top. but with this redirection, we would see a much quicker shift in those figures. And if we saw a 7.5% redirection of what is currently spent on drug control or punitive responses, we would see a 93% reduction in HIV-related deaths and a 94% reduction in new HIV infections. So essentially what I'm saying is we could end HIV amongst people who inject drugs, and we could really seriously tackle AIDS-related mortality as well if we just rethought how we spend the money that we currently spend within drug control. I just finally wanted to mention that while we have the privilege and the pleasure of coordinating the global state of harm reduction at HRI, it is very much a production of our sector. So while I stand here and I give you the information, I wanted to thank those of you who fed into it and to really highlight how many people around the world fed into this report and how much of a collective effort this really is. And we talk a lot about the global harm reduction movement, and it's a real privilege that so many of you fed into the report at the end. And for those of you who perhaps are interested in doing so in the years to come, please let me know. We're always looking for new people to feed in data or review. We'd be delighted to hear from you.